Thanks, Adeline. Delighted to be here. My name is Florian Eichler. I'm introducing the work group of Canavan disease, and I will be relatively short since I have two excellent speakers here who are going to be covering the basic science aspects and successes, also in gene therapy approaches, as well as the challenges around natural history and outcome measures on the clinical side. So Dominic Gessler from UMass and Annette Bley here span a nice international collaboration. Our workgroup membership, recently established, includes also David Pleasure from UC Davis, as well as Ayelet Zerem. David was unfortunately not here in person, but I believe Ayelet is somewhere here, and glad to also have representation from other parts of the world. We welcome other members into our work group in the future. So just as a brief introduction to Canavan disease caused by aspartate deficiency due to mutations in ASPA, this results in a spongy degeneration of myelin and astrocyte swelling. It is an autosomal recessive disorder due to biallelic mutations in this gene, and you can detect elevated N-acetyl aspartate in urine as well as in brain by MR spectroscopy or CSF. There's a very classic MRI pattern to this disorder. This disorder belongs to one of the most devastating leukodystrophies of early childhood, and I show you here some pictures from the early pathology as well as clinical descriptions here by Maurice Victor in 1960, where you see these children with enlarged heads and frontal bossing, reminiscent of the children that come to a clinic today. And so 50, 60 years, we are still struggling to change outcome in this population, but I'm very excited to see that today with technology we might be on the verge of doing so. The pathology shows here enlarged ventricles as well as the spongy degeneration in the brain. Canavan disease gene therapy has been on the preclinical, one of the preclinical success stories, as well as made pioneering steps within the clinical realm. I want to here give a shout out to Guangping Gao, who over many years contributed after Dr. Myrtle Canavan's first description of Canavan to cloning the gene and identifying ASPA, and Dr. Paolo Leoni, who I think is also here today, for really her pioneering work in instituting first CNS gene therapy. Mouse models were then developed by Dr. Madelon, and Dr. Gao also contributed to AAV9 serotype discovery and application of a lot of this into the mouse models, showing really the dynamic process of preclinical to clinical and clinical back to bench, that this is really a dynamic reverse translational process that needs to take place. So where are we briefly in terms of research challenges and successes? I think we have a very robust advocacy community in several patient registries. I will say that the advocacy groups in the US have found their way together, and also through the National Tay-Sachs and Allied Diseases community come together to help advocacy speak in one voice and to address the challenges at hand. There still is more work needed to align the different registries that exist, and clearly we want to make progress together in natural history. Mechanisms around NA metabolism, while they seem clear at first, are more complex. We have to understand substrate accumulation, also transport mechanisms of NA into brain could offer further targets for treatment. several animal models are promising tools, and cellular targets, astrocytes and oligodendrocytes have been identified. I think we're in an ultra-rare disease. We need to understand how to use shared control cohorts in a pre-competitive space. That is certainly a challenge for an ultra-rare disease like this, where we are lucky to now have several clinical trials ongoing. So natural history studies are happening at multiple sites, but still not fully aligned or uniform. And this is something that we're trying to tackle together. In terms of the clinical challenges and successes, molecular and biochemical testing approaches are well established, but we do not have newborn screening, and Dr. Bley will also be talking briefly about that. In order to really successfully institute gene therapy, we need to get to the children sooner. I think we are seeing proof of concept in animal models and in first clinical experience, but to optimize that, newborn screening clearly is necessary. Although natural history studies have documented the occurrence of seizures and time to G-tube dependence, full understanding of disease natural history remains a gap. We need to have standard of care guidelines coming together from European and US sites in order to understand how we can optimize care even for those children that do not qualify for gene therapy trials. What we're seeing in many leukodystrophies right now is that the actual segment of the population we can address with some of the more transformative treatments is rather small, and we need to help those that are too advanced for those trials. A cocktail of supplements is used by some families, but and is doing this in an open label fashion, but we do not have trials or evidence to support that at this point. There are no disease-modifying therapies available, so a lot still to do. I'm delighted to invite Dominic Gessler here first to talk. I think we've really moved from a lot of red in the past few years to green. Things seem feasible. There are wonderful preclinical models that we as clinicians now need to step up to and institute trials with, but understanding what is a meaningful outcome in a disease where children don't even sit up on their own, and trying to understand how we can garner patient and parent input to define and measure clinical meaningful outcome is tantamount. Go, Dominic.
Okay. Yes. First, I want to thank the organizers for this opportunity here, the great meeting. I'm very happy to present some Canavan data. Okay, I think I will skip this slide. Florian and Dominic already said a lot about the pathomechanism or basic informations of Canavan disease. Maybe just one thing that the knowledge about the pathomechanism of Canavan disease there's a lot known since decades, but still there are discussions or is ongoing research about the mechanism of demyelination. And as Dominic mentioned just very few minutes ago, it's still unclear what peripheral manifestations there are in the Canavan affected patients. So this is something there are some research groups looking for further better understanding what is the role of NAA metabolism in health and disease. There are some cancer cell findings stating there might be a role of the aspargine. There are other findings published and just mentioned the ketone bodies or even immune system or cell changes that should be closer at. I'm part of a research alliance in Germany that's funded by the German government, and we try to address these questions, the peripheral manifestations of Canavan disease. So there's a lot known for, as Florian mentioned already, decades, but still there's so much we need to know. It's a very, very rare disease, even as a leukodystrophy, it's quite rare. And we learned something by the natural history studies that are done over the last years, and we've found out some additional symptoms and some milestones of this disease. We learned that at the onset of disease that occurs between the first and the 7th month of life of these patients, there are usually many, between 1 and 12 symptoms that characterize the onset of Canavan disease. Most common is developmental delay, but other very common symptoms are low muscle tone, especially of the trunk, abnormal eye movements, the progressive macrocephaly, and so on, as stated here in the graph. The macrocephaly is a point. This curves here were published last year, and it clearly shows that Canavan patients develop this macrocephaly within the first year of life, and then all have a macrocephaly that's going parallel to the percentiles. All these data, or the patient informations that were used, were from the cohort that we analyzed. 2 years ago, there was the data cut of the analysis. During the last 2 years, we had more patients that we cared for, and it was quite interesting that there additionally were those very mild Canavan patients. There were already publications in the literature about these, but we found that the head circumference of these especially mildly affected children were all within the normal limits, so below the 97th percentile. So the two males here are showing symptoms. They didn't develop normally from the beginning on, but they are able to walk, to run, to speak, even if they have language, some delay in the language development, and the females as well. And that's, I think, a very important finding, because the phenotype is so, is broader. Okay, so this are results from the study that's published last year, and the majority of Canavan patients is very severely affected. So more than 90% never learn to sit, to speak, to walk, have no continence, or they are not able to feed themselves. Sorry, I hope the micro is working. And more than half of, more than 50% only, they don't gain the ability to track visually. Very few gain head control, or learn to reach for an object. Most of those abilities are lost within either months, or very few patients keep these abilities for years. Symptoms as spasticity, abnormal movements of the body or the eyes, development of seizures are very, very common findings. So to summarize this, most patients are really severely affected, and the differentiation, if they improve, if they would profit from a treatment, would be very easy, because they are so severely affected. The survival is that almost 3/4 of the cohort reached the age of 10 years, and something that might be useful, but it's not helpful for, let's say, a few years treatment trials. But in the end, of course, that's important information as well. And for the severely affected patients, let's say the classical Canavan patient, it's we developed a Canavan disease rating scale score where we could differentiate the patients if they are very, very severely affected or only severely affected. So giving scores for developing normal with certain functions or showing mild deficits or pronounced deficits. And so if a patient is normal or appropriate to age, he has 0 points, and if the patient is severely affected, they have the maximum score of 22. And the score is still, let's go back, it still needs to be validated. We use it since it was published, and it seems to be a very good tool. There are a few problems if we analyze or use retrospective data. It's sometimes not possible to get all the items, all the information. So sometimes it's or we consider, we discuss if it's better to do a percentage of the to calculate a percentage of the score. To use more information that we have retrospectively. And the second point is, if we add the very mild, let's say atypically mild Canavan patients, this score here is not differentiating good enough, because these patients walk around and the deficits are in fine motor functions and cognitive functions. This is something that should be addressed in the future, or there needs to be other assessments that address this patient. Okay, there are all these functions and symptoms that I mentioned. Each could be a meaningful outcome measure. There we started to analyze some of them only function by function, and this is just an example showing the head control analyzed with the CDRS, with the Canavan disease ratings scale, and it's 176 observations over time, so the age at assessment, and as you see, the green dots are very rare, so only few patients have a normal head control. Most have pronounced problems or no head control. Some have minor head control. So it's actually a very good outcome measure to address the dysfunction of these children. There are 2 clinical trials with gene therapy ongoing. If you look at clinicaltrials.gov, you can see the outcome measures that are used. One gene therapy, as mentioned before, is using an AAV9 vector via an intravenous infusion. And there are a lot of assessments. Some are discussed in the Eichler group in detail, and there are a lot of different questionnaires and assessments done, and we have to analyze and to validate in the future which are the best here. The same goes for the myrtle gene therapy, that it's has a different administration route of the vector that's directly targeting the oligodendrocytes via neurosurgical procedure into the brain. But still, besides those motor, developmental, quality of life assessments, seizure assessments, there are the levels of NAA in different compartments as CNS, as urine, as in blood, used to measure the outcome and the effect of the treatments. Okay, there are still, as mentioned before, some unmet needs. So the score that was developed needs to be validated. As mentioned, the percentage of the score, if used with retrospective data, might be helpful. And for the very mild affected patients, it might be necessary to use further assessments to address the cognitive and fine motor functions. So complex tasks would be necessary as well. We need to see what of the mentioned symptoms, abilities, milestones are significant and predictive. And I didn't really address the MRI part, but still being a leukodystrophy, this is a major part of the diagnostic ability to follow this disease. There is not a MRI score established yet that might be helpful. Also, it would be very helpful to have more data about the normal levels of values of NAA in healthy children that change over the time of development, and of course of non-treated Canavan patients. That it's would be very important to have a comparison here. And as addressed by Dominic before, the metabolic changes that might be additional outcome measure or biomarkers. It's very important to learn more about that in patients, and other peripheral findings, if immunological or others, would be important to see if if they play a role. And as addressed before, if we even if there are effects, if patients, we know from Dominic's report about mice, so if you treat older juvenile affected mice, we don't know yet what the effect is in patients, and we think, or from the things that we know, we guess that it's important to be early. And so the newborn screen, the development of newborn screening, developing the measurement of NAA in dry blood spots, and establishing newborn screening seems very important to us. Thank you.
Be happy to take any questions. Start there.
Thank you so much for an excellent presentation. My question is for Dominic. I think the gene therapy work is excellent. And I'm curious, I see that you're giving it intravenously. Have you thought about or tried to explore intraventricular or intrathecal and seen any differences in responses?
And that's a very good question.
It's on.
It's on. Good. Okay, cool. The question was if we have explored intracranial or intraventricular injections. We have. When we follow the mice long term, like a year and longer, when we compare them side by side, we see that the intraventricular injection is not as prolonged in terms of efficacy. And kind of sidetracking from other diseases, we know that in other leukodystrophies or CNS disorders, in larger animals, when they treat the brain only, over time they see a peripheral phenotype. That's kind of the main, even though there's not much data out there, that's kind of the main argument for us to go the IV route. Even though I'm a neurosurgeon myself, so I'm not afraid of injecting into the brain. We still prefer a less invasive strategy if that can be achieved.
Hi, I have a follow-on question to that. So do you think the lack of efficacy in the older animals is due to the severity of the disease having progressed or the lack of distribution to the brain? Because AV9 intravenously doesn't really cross the BBB very well. And so I'm just thinking in patients, if you deliver it after they're a couple months old, how much are you going to actually get in the brain?
Yeah, that's a very good question. So we actually have been doing extensive vector genome distribution studies in mice as well as in monkey. Even after 1 year, we still see very high levels of the AV genome as well as the transgene expression. In AV, it has been used in other diseases like SMA. AV9 is by far at the moment the best capsid we have that it has been naturally discovered for targeting the brain by IV. And I think Kevin Faust showed in his Nature Biotech paper actually that AV is very efficient crossing the BBB, AV9 in particular.
Here, let's go. The microphones turn themselves off, so if it's not on, just
Okay.
they're trying
This
to
is on,
save
right?
energy. Yeah.
Yes. Hi, everyone. Just asking a question about your experience with the patients. I follow up patients for 25 years now. We have a large natural history, and throughout these past 25 years, we have diagnosed several patients who are affected by the atypical form, right? Some have been published. You probably have your own knowledge of these patients. And so the interesting part is that these patients are diagnosed with Canavan disease because of elevated NAA in urine. Mutations are also identified. Some are then labeled as mild, but patients do have extremely highly elevated NAA in urine and in the brain. However, some of them develop, let's say, completely normal. We have 2 patients that we've followed up now for over 15 years. Their unique mutations was identified and published by our group. And so how do we explain patients, and maybe even among us, people with extremely elevated NAA and absolutely normal development? With that said, discussing, for instance, patients with driver license, go to college, and so this is just appearing more and more now that there's just more attention on just identify even if there is an issue related to mild seizure, there are just organic acid analysis in urine, and so there are more and more patients being diagnosed with Canavan disease who are basically atypical and normal with elevated NAA. So that's.
Yes, I think it's a very important question. That's a finding that we see it ourselves, and we've tried to correlate NAA in urine and in blood with the CDRS, with the score, and in some patients there seemed to be a correlation, but there are, as you mentioned, some patients where the correlation is not really working. That's the reason I mentioned it. At an unmet need, we really need to better understand the let's say normal or the levels over time, because the correlation is not really in every patient the explanation. So I don't know if that helps.
Sure. We'd love to chat more about this. In the classic patients, we obviously see a strong correlation to the imaging, the myelin development itself, the swelling, the atrophy over time. Whether in those patients where we see NA elevations and there is not this pattern, are there modifiers? Is there mosaicism? Are there other factors that are contributing? I think it would be very exciting and might open up new therapeutic avenues as well.
Dominic, I wanted to come back to the motor testing that you did. Did you separate, I know that there was, there's male and female, but do you separate out by alpha versus non-alpha animals? Because will probably makes a difference in how long they stay.
That's a good question. I'm not sure how to identify. You mean alpha?
Oh, an alpha male and a female.
Yeah. But I'm not quite sure. I'm not aware of what would be a good way of assessing it. We basically went just by sheer numbers. We had 12 male and 12 females per group to really try to increase the N number to minimize those those potential influences. Similarly, the daytime would also potentially affect the testing. So we typically do that all consistently. And most of the testing is actually done blinded by people who are not even part of this study.
So we're just going to take 2 more questions, one there and one there. Thank you to the speakers. And I'm sorry, 2 quick questions for Dominic. One, for the mildly symptomatic juvenile mice, would you be able to equate what the age equivalent would be in a human infant? And then the second question is, for the dose, I'm not sure if I missed it, if you're comfortable with sharing the dose, and largely because with AV9, the 2.0 e to the 14th has been sufficient for motor neuron biodistribution, and anything above that, we've seen the cases of toxicity in general with systemic delivery. Anything below that can be subtherapeutic. Thank you.
Yeah, so to your first question, that's actually a question that I get a lot. And when you survey the literature, while people obviously try to predict and develop prediction models to correlate mouse age, brain age and development to humans, it's still, in my opinion, more or less a guess. But if you were using those tools, then a juvenile mouse corresponds to a 2 to 3 year old human.
2 to 3 year old.
Yeah. With your second question, with regard to the dose, we uniformly treat our neonates with a dose of 4 times 10 to the 11. They are 1.6 gram roughly, so you can kind of scale it up to the per kilogram dose. And everything that's juvenile or older gets basically a 1 log higher dose, so 4 times 10 to the 12. And then those mice, depending on the age, the dose varies, but it's roughly in the range of 2 to 2.5 times 14 to the per kilogram.
I have a question to the altered metabolism of the mice, and the first question is whether this ketone bodies or the elevation in the ketone bodies in the serum would be coupled to a reduction in the blood glucose levels. Maybe you said it, maybe I missed it. And secondly, whether this is also found in patients. And third, whether you regard this as now a marker, part of the pathogenesis, or more the attempt of the brain or of the body to to ameliorate internally the disease?
Yeah, that's it's a fantastic question. I cannot comment too much on the metabolism because that's a heavily researched part in our group right now. There are very distinct findings that seem to be not only specific to Canavan, but actually translate to other diseases as well. As you probably could guess, that's your question, hence your question. We are also trying to explore if the beta-hydroxybutyrate is contributing to the disease pathomechanism, or if it's just really a secondary or even tertiary effect.
When do you see the elevation at what age?
The earliest we have looked is 25 days of age. Yeah, the latest we have looked is, I think, several months old, depending on that mouse model. It's present in both mouse models. And then in terms of, maybe I'll let you comment, or Annette, on if we see that in patients, because it's something that Annette has been working on to see how much of those findings are translatable to humans.
Yes, so we looked for that, but we are still not really sure how to interpret those findings. So we found some BHB elevations in urine. They were found in serum, some elevations, but it's not really, it's not all of them. It's just a part. We also addressed the question, tried to find out retrospectively if the blood sugar was abnormal. Then we couldn't prove that, so there was no abnormality correlating with that. We think. We are not sure if what the mechanism is, if it's a metabolic acidosis, and if there might be some respiratory compensations that are eventually shown by the blood gas analysis, but it's something we just start to address since nothing proved yet.
All right. With that, we'll thank our speakers in the work group.